Hello and welcome. Good morning, good afternoon, and good evening. My name is Stephen Peeler, Executive Director of the IDSA Foundation. We're very excited to have you join us today for the kickoff of World Antimicrobial Awareness Week, which is a global campaign that aims to raise awareness of antimicrobial resistance worldwide and encourage best practices among the general public, healthcare workers, and policymakers to slow the development and spread of drug-resistant infections. Today, we're pleased to present the next webinar in our Dr. John G. Bartlett Memorial Education Series entitled Gram-Negative Resistance, Hiding in Plain Sight. We have two excellent speakers who will dive into the burden of gram-negative resistance. This webinar, as with all of our programming, is brought to you by donations and supporters like you, as well as today's program is brought to you by Platinum Industry Partner of the IDSA Foundation, AbbVie. Visit our website, idsafoundation.org, to access prior webinars, sign up for our monthly newsletter, follow us on social media, and stay informed about the mission-critical work of the foundation. Our goal is to reduce the burdens of infectious diseases worldwide. Before I tell you a little bit about our first speaker, I'd like to invite all of you and all of our attendees to enter your questions at any point throughout the program using the Q&A button. To get started, I'd like to introduce Dr. Jessica Howard Anderson. Dr. Howard Anderson is an associate professor of medicine at Emory University School of Medicine and the associate hospital epidemiologist at Emory University Hospital in Midtown. She completed her medical school residency and chief residency at University of California, Los Angeles. Dr. Howard Anderson completed her fellowship training in infectious diseases at Emory University in 2021, and during her fellowship obtained a Master's of Science in Clinical Research with the NIH-funded Antibacterial Resistance Leadership Group. Dr. Anderson's research focuses on the epidemiology of multi-drug resistant gram-negative organisms using novel methodologies such as DOOR, desirability of outcome ranking, to better understand the clinical outcomes of patients infected with multi-drug resistant organisms. Employing diagnostic stewardship to improve antimicrobial prescribing and decrease healthcare associated infections. She's an active member and serves on many committees within the Society for Healthcare Epidemiology, SHEA, and the Infectious Diseases Society of America, IDSA. Please join me in welcoming Dr. Howard Anderson.
Thanks so much, Stephen, for that kind introduction, and thanks to the IDSA Foundation for the invitation to speak today. So I'm going to kick us off, and then I'll hand it over to Dr. K to finish the talk. So I don't have any disclosures. And here's the outline for our talk today. So I'm going to tackle numbers 1 through 3, and then Dr. K will talk about numbers 4, 5, and 6. So I'll start with talking about the epidemiology of gram-negative resistant bacteria with a focus on carbapenem-resistant Acinetobacter, carbapenem-resistant Enterobacteriaceae, multi-drug resistant Pseudomonas, as well as extended spectrum beta-lactamase producing Enterobacteriaceae. I'll then talk about the impact COVID-19 has had on gram-negative resistance, and end with talking about the effect gram-negative resistance can have on clinical outcomes. So as I start the talk today, I want to remind everyone that today is the first day of World Antimicrobial Awareness Week, which is a global campaign to raise awareness of antimicrobial resistance and to help stop the spread of antibiotic-resistant infections. In 2019, it was estimated that approximately 5 million deaths were associated with bacterial antimicrobial resistance, or AMR. And these data were produced from a landmark study that came out earlier this year by a large group of global investigators, where they took data from numerous different sources from over 200 countries to estimate the burden that's associated with antibiotic resistance. And so they found that nearly 5 million deaths were associated with bacterial AMR, and that over 1.3 million deaths were directly attributable to AMR. And what they meant by that was that if a patient were to have a susceptible infection as opposed to an antibiotic resistant infection, that the death could have been prevented or avoided. Using these numbers, deaths due to antimicrobial resistance would have been the third leading cause of death in 2019, behind only ischemic heart disease and stroke for that year. So this is clearly a large issue and one that we need to continue to tackle and raise awareness for. So in that study that I just mentioned, what they also did was look at the burden of deaths, or the number of deaths attributed to each individual bacteria. And what they found was that 75% of the deaths attributable to AMR can be accounted for by just 6 different bacteria. And 4 out of those 6 were due to gram-negative bacteria, so E. coli, Klebsiella pneumoniae, Acinetobacter baumannii, and Pseudomonas aeruginosa. And so that's part of the reason we're going to focus on gram-negative pathogens today. Many of you are probably familiar that in 2017, the WHO came out with a priority list of antibiotic-resistant bacteria to guide research and the development of new drugs. And in 2019, the CDC also updated their antibiotic resistance threat report that was originally published in 2013. And here they highlight the major threats in terms of antibiotic resistance. And it states that they account for things like the incidence of the organism, the transmissibility, and also the availability or lack thereof of therapeutic options for the different organisms. So what are the most concerning gram-negative pathogens that we'll discuss today and that are included in these 2 reports? So in the WHO report, all 4 organisms that were included in their highest tier, their tier 1, which they deemed a critical need. All of these were gram-negative, so you can see them listed here. It includes carbapenem-resistant Acinetobacter baumannii, or CRAB, carbapenem-resistant Enterobacteriaceae, or CRE, 3rd-generation cephalosporin-resistant Enterobacteriaceae, which can sometimes be thought of as a surrogate for ESBL-producing Enterobacteriaceae infections, and carbapenem-resistant Pseudomonas aeruginosa. The CDC in their 2019 antibiotic resistance threat report also similarly included essentially these same 4 organisms with slight differences in how they defined multi-drug resistant Pseudomonas. Carbapenem-resistant Acinetobacter and CRE were both termed urgent threats, and ESBL-producing Enterobacteriaceae and multi-drug resistant Pseudomonas aeruginosa were deemed to be serious threats. So delving into these 4 organisms a bit more, I'll start with talking about ESBL-producing Enterobacteriaceae infections, because out of the 4, this one causes the most number of cases. In 2017, it was estimated to cause nearly 200,000 cases in hospitalized patients. And I think what is most striking about the epidemiology of ESBL infections is the percentage of patients with ESBL producing infections that do not have any recent healthcare exposures. And so in the CDC threat report, they estimated that close to 50% of patients with these infections were thought to be community-associated infections. So they did not have recent healthcare exposures, and they did not develop the infection significantly into one of their stays in a healthcare setting. Also, quite alarmingly, there's been an increase in ESBL-producing Enterobacteriaceae cases over the last 10 years or so. This was a study done by Jernigan et al. In 2020, where they looked at cases of ESBL-producing Enterobacteriaceae from 2012 to 2017, and found that there was an over 50% increase in hospitalized cases. And this increase was largely driven by community onset cases, which you can see represented here by the light blue shading. And the dark blue shading, you can see, represents hospital onset cases, which actually largely remained stable over that time period. Moving to multi-drug resistant Pseudomonas aeruginosa, carbapenem-resistant Enterobacteriaceae, and carbapenem-resistant Acinetobacter. You can see that I've organized these in terms of number of infections that they were associated with. In 2017, Pseudomonas was estimated to cause over 32,000 cases of multi-drug resistant Pseudomonas infections. CRE was estimated to cause 13,000 cases, and carbapenem-resistant Acinetobacter was a little over 8,000. And in the 2019 report, there was actually a little bit of optimism. As compared to 2013, rates of these multi-drug resistant organisms had either remained stable or slightly decreased. However, I'll note that this was, of course, prior to the COVID-19 pandemic, and so we'll get into the impact that COVID has had in some of the next few slides. In terms of risk factors for these organisms, unlike ESBL, what I just showed you on the last slide, we really worry about patients developing infections with these organisms in patients that have had significant healthcare exposure, so patients that have been in the ICU for a long time, or patients that live in long-term care facilities, specifically long-term acute care hospitals. Patients that have indwelling devices, such as central lines, urinary catheters, or are mechanically ventilated, are also at risk for each one of these organisms. And of course, significant antibiotic exposure is also a risk factor for developing one of these multi-drug resistant organisms. As Dr. K will get into, these organisms are often extremely drug resistant, making treatment quite challenging. And we also know that each of these organisms has been associated with environmental contamination, and that the healthcare environment can serve as a reservoir for many of these organisms, leading to healthcare transmission as well as healthcare associated outbreaks. Water sources, and particularly sinks, have been implicated in many healthcare associated outbreaks. And long-term acute care hospitals are also thought to be an important reservoir for some of these organisms. And in some regions in the US, it's been estimated that as much as 30% of patients in long-term acute care hospitals could be colonized with CRE. I'm not going to spend a lot of time on this slide, but I just wanted to show you all of the different places that CRE has been identified from the healthcare environment. This was from systematic review. You can see that sinks have been identified the most frequently in 10 different studies, but CRE has also been identified in many places in the hospital room, as well as on healthcare worker hands, and on various different instruments that we use in the healthcare setting. There's also a significant amount of geographic variation and disparities when we think about AMR and the burden of AMR. And so in that Lancet study that I mentioned earlier in the talk, the highest rates of death from antimicrobial resistance occurred in sub-Saharan Africa, as well as South Asia. And there's a significant amount of variability in the prevalence of resistance. I'm not going to have time to go into each individual organism, but I wanted to just show you one example here, looking at carbapenem-resistant Acinetobacter. So what you're seeing on this map are the percentage of Acinetobacter baumannii isolates that are carbapenem resistant. And you can see quite alarmingly that some countries that are the orange to dark red, greater than 70% of the Acinetobacter isolates can be carbapenem resistant. And this is in contrast to some countries that are sort of green or blue that have about 5 to 20% of their Acinetobacter isolates resistant to carbapenems. Then I'm going to transition into talking about the impact that COVID-19 has had on antibiotic resistance. A few months ago, the CDC actually issued a special report on COVID-19 and the impact it's had in the US on AMR. Unfortunately, the news is not good, and so this report showed an alarming increase in the rate of resistant infections from 2019 to 2020, and primarily in infections that started during the hospitalization. They noted an increase in 8 out of the 18 bacteria listed in the 2019 CDC threat report. And also, because of the pandemic and shifting resources and priorities, The 2020 data that the CDC relied on in terms of tracking antibiotic-resistant infections and surveillance, that data was delayed or unavailable for 9 out of the 18 pathogens in that original 2019 threat report. So what happened in terms of the 4 main organisms that we've been discussing: crab, CRE, ESBL, and multidrug-resistant Pseudomonas? Well, you can see that overall, the change in rates from 2019 to 2020 increased most significantly for carbapenem-resistant Acinetobacter with a 35% increase. But for CRE, ESBL, and Pseudomonas, there wasn't, the numbers were relatively stable. But what's really more alarming is the increase in hospital onset cases here for all of these organisms. You can see crab, again, with the most striking increase of 78% increase in the rates of hospital onset infections. And this is largely because many hospitals during 2020 actually reported healthcare-associated outbreaks of carbapenem-resistant Acinetobacter, some of them in COVID-19 ICUs. But you can see for CRE, ESBL, and multidrug-resistant Pseudomonas, there was also about a 30% increase in hospital onset cases from 2019 to 2020. So why was there this increase in these multidrug-resistant organisms? Well, like anything, it's multifactorial, and I think a lot of us intuitively know some of these reasons. We remember that patients in 2020 did not want to go to the hospital unless they were really sick. We were deferring elective surgeries, elective admissions, and so patients in the hospital in 2020 were quite sick. They often had longer length of stay, and as I already mentioned, increased healthcare exposure is associated with increased risk for these organisms. Patients had increased use of devices, including central lines, urinary catheters, and ventilators. And the COVID-19 pandemic also changed, I think, how we took care of patients with these devices. We know that there was a lot of fear of COVID in the first few months of the pandemic, and this changed how often staff went into the rooms and changed a lot of our infection prevention strategies. To use a cliched term, hospitals were pushed to the breaking point, both with patients, but also there were staff shortages, PPE shortages. And again, this made it difficult to follow our normal infection control guidance. And then lastly, we saw an increased use of broad spectrum antimicrobials, and one study estimated that in the first few months of the COVID-19 pandemic, approximately 80% of patients who were hospitalized with COVID also received an antibiotic. So to end, I'm going to talk about how gram-negative resistance can impact clinical outcomes. And I'll start with highlighting that the initial antibiotic choice or your empiric antibiotic regimen is very important. So I'll highlight just this one retrospective study that looked at over 1,000 patients with severe sepsis or septic shock from gram-negative bacteria. And they actually had bloodstream infections, and they looked at risk factors for in-hospital mortality and found that not receiving an active empiric antibiotic was associated with increased hospital mortality with an odds ratio of approximately 4. And the largest or biggest risk factor for not receiving initially active antimicrobial therapy was having a multi-drug resistant infection. And so multi-drug resistance was associated with an odds ratio of 13 of having an initial antibiotic regimen that didn't cover that pathogen in the blood. Turning now to 2 meta-analyses focusing on some of these multi-drug resistant organisms I've been discussing. So on the left, you'll see a forest plot of studies comparing ESBL producing versus non-ESBL producing Enterobacter ACA bloodstream infections. And as you can see here, ESBL producing infections were associated with increased risk of mortality with a cumulative relative risk of about 2. On the right is another meta-analysis of studies comparing resistant versus susceptible Pseudomonas aeruginosa infections. This was not limited to bloodstream infections. And similarly, patients with resistant Pseudomonas infections were associated with having increased mortality with, again, a relative risk of about 2. This increase in mortality is driven by many factors, but I think 3 main ones to point out here are that there are patient factors. So we know that patients with multi-drug resistance organisms are likely sicker at baseline and at risk for worse outcomes. There can be delays in active antibiotic therapy, as I just showed you on the last slide. And of course, with some of these very drug-resistant organisms, there actually can be a lack of therapeutic options, or the antibiotics that we have may be quite toxic themselves. So I'll conclude with reminding you all that mortality rates for these infections remain high, specifically when we're looking at invasive infections. The CDC Emerging Infections Program, which performs active population-based surveillance for numerous sites around the country, has looked at in-hospital mortality as well as 30-day mortality if the patient was discharged prior to 30 days. And from 2012 to 2015, they found that for invasive CRE infections, the mortality rate was almost 30%. And for invasive crab infections, the mortality rate is a little over 40%. Globally, the Lancet study this year showed that ESBL-producing Enterobacterales, crab, and carbapenem-resistant Klebsiella pneumonia each was estimated to cause 50 to 100,000 deaths per year. So we clearly still have a lot of work to do, and I just want to close with reminding everyone of the theme of World Antimicrobial Awareness Week, which is preventing antimicrobial resistance together. Thank you for your time, and I will turn it back to Stephen.
Thank you, Dr. Howard Anderson. You're right, we definitely have a lot of work to do. Really appreciate the talk. Now it's my pleasure to introduce Dr. Kay. Dr. Kay is Chief Division of Allergy, Immunology, and Infectious Diseases, and a professor of medicine at the Rutgers Robert Wood Johnson School, Medical School. He's devoted his career to the prevention and effective management of health care-related and associated infections. In addition to serving a variety of quality improvement and administrative roles in infection prevention, antimicrobial stewardship, and quality and patient safety, he has served on national, international clinical guidelines committees. Dr. Kay's research interests include prevention and treatment of antimicrobial resistant organisms, prevention of healthcare-associated infections, and innovative approaches to antimicrobial stewardship. He has a long, productive track record of federal funding, receiving federal funding for research in the prevention of multi-drug resistant organisms and healthcare-associated infections, including groundbreaking clinical trials. Dr. Kay received his medical degree from the University of Pennsylvania and completed his internal medicine residency and infectious diseases fellowship at Beth Israel Deaconess Medical Center in Boston, Massachusetts. During his fellowship, Dr. Kay earned his master's in public health from the Harvard School of Public Health. Dr. Kay has authored over 350 peer-reviewed articles and 20 book chapters, and is frequently presented on this topic of original research, national and international conferences as well. He is a past president of SHEA and is an internationally recognized expert in healthcare epidemiology, antimicrobial resistance, and has been invited to speak on these topics throughout the world. It's my honor to introduce Dr. Kay.
Thank you so much, Stephen. That was wonderful. You make me sound good, so I appreciate that. Jessica, thank you for your excellent talk. And I'm going to jump right in because we don't have a lot of time and we want to make sure that we have plenty of time for questions. Talk a little bit about ESBLs. I want to talk about some of the newer agents that have become available recently. I then want to focus on treatment of carbapenem-resistant gram-negatives, and we're going to move pretty quickly. So I think it's going to be important. These slides will be available. You'll be able to look back for specific bug-drug combinations that might be effective treatment approaches. And I want to wrap up by talking about prevention of resistance, what works, what might work, what doesn't work, and what the future might hold. ESBLs, as Jessica showed, are on the rise, primarily driven by CTXM, which is a novel, not so novel anymore, but as of past 15 years, it came onto the scene and promptly became the most common beta-lactamase, extended spectrum beta-lactamase produced in the world in very short fashion. This has led to a skyrocketing incidence of ceftriaxone resistance in E. coli, which again is a surrogate for ESBL production. And again, is becoming more and more common, not only in the hospital, as Jessica mentioned, but also in the community. Carbapenems have been our go-to treatment option for ESBL producers. And there really wasn't a lot of wonderful clinical data to support that. There was a landmark study done by Harris et al., which compared the Marino study, which compared piperazole and tazobactam to meropenem for treatment of bloodstream infection due to ESBL producing E. coli or Klebsiella pneumonia. Again, ceftriaxone resistance was used as a surrogate for ESBL production. Essentially, primary outcome was 30-day mortality. And what you can see is, unfortunately, I think the authors were hoping that piperazole and tazobactam might be non-inferior to meropenem, and we'd be able to take some of that meropenem use and convert it to piperazole and tazobactam. But the primary outcome here, mortality, about a 12% mortality rate in pip-tazo arm versus less than 4% in meropenem. So significant survival advantage with pip-tazo. And no matter how you slice the data, looking at clinical outcomes, microbiologic outcomes, different time periods, always it seemed that meropenem was favored over piperazole and tazobactam. So this left us with the conclusion, appropriately, that meropenem was really superior to piperazole and tazobactam for ESBL-producing bacteremia. Just a couple side notes. I want you folks to remember the study did not look at de-escalation of antibiotics. It didn't look at starting with meropenem and then switching to a narrow spectrum agent such as ertapenem or a non-carbapenem when the patient was doing better or when the blood cultures cleared. So these results of the study don't mean that you can't, that if you start off with meropenem or imipenem, you don't have to stick with it necessarily for the entire duration of therapy. Especially if, there are oral options or the patient is doing much better, you can de-escalate or convert to oral therapy. The other important take home here is, when I started my training, we routinely treated gram-negative bacteremia for 14 days. In this study, the average duration of therapy was 7 days in both study arms. So more and more, I think for many cases, not all, but many cases of gram-negative bacteremia, we can shorten duration of therapy. I think this is an important take-home message from this study that I think can lead to a decreased selective antimicrobial pressure and decreased resistance issues in the future. The problem with more carbapenem use is now, as we're seeing more ESBLs in the hospital and more ESBLs in the community, we're going to be using more carbapenems. We're going to use more carbapenems for definitive therapy due to ESBL production, and we're probably going to be using it more empirically. Because, if someone's very sick, you want to make sure that you're covering potential ESBL infection. That's going to equal empiric carbapenem use. And I'm going to show you why, with this study, why this is problematic. Rahal et al. Studied with the impact of a formulary change, right? Not really a formulary change, but an intentional change in the use of on-formulary agents. The workhorse agent was a third-generation cephalosporin in this New York hospital. And essentially, there was a conscious effort to move away from cephalosporin use and substitute imipenem use as a workhorse antibiotic for suspected and confirmed gram-negative infection in the hospital. The reason for this was that a high ESBL rate, which third-generation cephalosporins are a major risk factor for ESBL producers. And so within 1 year, there's an 80% reduction in cephalosporin use and broad-spectrum cephalosporin use, and 140% increase in imipenem use. While the impact on ESBLs was effective, unfortunately, there was almost 70% increase in imipenem-resistant Pseudomonas. So you can see here that within 1 year, while the ESBL problem might have improved, they ended up with a bigger problem that they didn't bank on, basically being high rates of carbapenem resistance. So this leads us to what I think is the focus of our talk, which is carbapenem-resistant gram-negative rods, which I think, as Jessica pointed out, are emerging problems in Pseudomonas, Acinetobacter, and Enterobacter rallies. Jessica went through a lot of the risk factors and the fact that these are major headaches in the hospital, not only for clinicians, but also for infection preventionists, also for antibiotic stewards. I think the carbapenem-resistant gram-negatives are currently the major, maybe the biggest ID-related inpatient threat in hospitals across the world. And the reason is that these are not easy to treat. We have made some major advances, but we still have many, many unmet needs. I should mention carbapenem resistance is often not isolated. It's often associated with multi-drug or extensive drug resistance to a multitude of other beta-lactams and other antibiotic classes. Our antibiotic armamentarium has really evolved in the past several years. Back in as recently as 2014, all resistant gram-negatives were really only treated with polymyxins. We had one tool in that toolbox, and that essentially was a polymyxin. So that's what we used when we had multi-drug or carbapenem-resistant gram-negatives. We didn't have a lot of options. Now, as of 2015, we now have lots of options. I'm listing several that we'll briefly talk about. These have all been new since 2015. And an important thing is these aren't just a variety of different hammers. These are a variety of different tools like wrenches, saws, and different types of hammers, drills, etc. And there's not one size fits all. There's not one of these newer antibiotics that will treat all or even most of our resistant gram-negatives. So it's gotten a lot. We have many more choices, but also management and treatment of resistant gram-negatives has gotten a bit more complicated. These are newer antibiotics since 2015. These are all beta-lactam, beta-lactamase inhibitor combinations. The first cefepozine tazobactam, the special sauce here, the new kid on the block is the beta-lactam. It's an advanced generation cephalosporin with very great activity against Pseudomonas, and it's coupled with our old friend tazobactam from piperazole tazobactam fame. The other three antibiotics listed here, you'll notice the old school beta-lactam backbone, ceftazidime, meropenem, imipenem, and these are coupled. The special sauce with these antibiotics is the beta-lactamase inhibitor, avibactam, vaporbactam, and relebactam. These are two additional antibiotics that are non-inhibitor combinations. The first is ribavacycline, which is an advanced tetracycline, a synthetic tetracycline, which is sort of a souped up version of tigecycline, is a poor man's way to think about this. And cefiderocol, which is an even more advanced generation cephalosporin, which is very broad in vitro activity, but it is not coupled with the beta-lactamase inhibitor. Important thing to notice is we talk a little bit about CRE and carbapenem-resistant Enterobacterales. The good news about understanding carbapenem resistance with Enterobacterales is that carbapenem resistance is really driven almost exclusively by carbapenemase production. Those carbapenemases most commonly in the US are the KPCs or class A, and we're seeing more of the MBLs, the like NDM, the New Delhi metallo-beta-lactamase. These are class Bs, and least common now are the class Ds, OXA48, which can also be produced and cause carbapenem resistance. Carbapenem-resistant Enterobacterales, if you see a KPC producer, then you can use any of our new beta-lactamase inhibitors. I've written down the backbone beta-lactam and in combo with the inhibitor so that you can relate them to what those combinations might be. If you are dealing with an OXA48, ceftaz-avi will give you coverage not only for the KPCs, but also against OXA48. What you'll notice here is the MBLs, which most of the one we have to worry about and deal with is really the NDM. Nothing touches this. None of the inhibitors touch the NDM. And unfortunately now, the new metallo-beta-lactamase is the second most common carbapenemase produced in cases of CRE. And this is a major problem because we don't really have an effective beta-lactam, beta-lactase inhibitor combination that can treat the NDM producers. What we do have excellent treatment for the KPC producers. We have ceftaz-avi, we have meropenem-vaborbactam. Also, imipenem-relebactam has good activity against KPC producers, but I don't think we don't have the amount of clinical data or experience as we do with these two agents. Ceftaz-avi added a broader coverage against OXA48s. But again, if you're dealing with the MBL producers, which unfortunately I think we're deemed to deal more with, we can't use any of the inhibitor combinations. That's when this new broad spectrum cephalosporin cefiderocol, which is a siderophore cephalosporin, it basically utilizes the iron scavenging necessities of bacteria to sort of come in through enter the periplasmic space and the cell, the bacteria, and the targets for its activity really through the same mechanisms that iron is scavenged. And this is novel activity. And this has shown to have very good in vitro activity against the NDM producers. There is some clinical data that supports its efficacy in treating MBL producers, but we have limited clinical experience so far, at least on a published level. Also, the combination of astrinum and monobactam, coupling it with avibactam in sort of a backroom way to do that by giving two available antibiotics, astrinum and ceftazimab-avibactam. The combination of astrinum and avibactam also can be active against these MBL producers. But again, these MBL producers, I think, represent an unmet need. While we do have some treatment options, I think there is concern that we might need some more cards up our sleeve in the not too distant future as we see resistance emerge to all of our newer agents. Let's switch to Pseudomonas. And Pseudomonas is a complicated bacteria, and there's multiple mechanisms of resistance that it can impart. You can see here, just focusing on the carbapenems, often rather than carbapenemase production, which Pseudomonas certainly can produce carbapenemases, but more commonly in the US, we see a combination of porn mutations and which decreases the permeability of the bacteria and entry of the carbapenems to their site of activity. With AMPC hyperproduction, usually combinations can lead to imipenem resistance, and usually combinations of porn changes and efflux pumps lead to meropenem resistance. So again, it's quite complicated beta-lactam resistance. We do have good agents to treat resistant Pseudomonas, ceftolozane, tazobactam, ceftazimab-avibactam, imipenem-relebactam, all have activity. There are differences in the beta-lactam anchors as well as the inhibitor for each of these. And I think susceptibilities to these agents will vary at an institutional level. When I was at the University of Michigan, ceftaz-avi was their single most common pseudomonal agent. I think when I'm now at Rutgers Robert Wood Johnson, we're seeing more activity among ceftolozane and tazobactam. So it's a good discussion to have with your micro lab. I do think cefiderocol has excellent in vitro activity, but I think the jury is out regarding as to how effective this will be for serious pseudomonal infections. We don't have, I think, enough clinical data to rely on this unless there are no other options. And right now, in most cases for highly resistant Pseudomonas, we do have 3 good options that I just talked about. I think Jessica pointed out that, carbapenem resistant Acinetobacter is becoming more common, particularly in this area of COVID. Again, resistance is complex. There is a high incidence of carbapenemase production, usually the serine class D oxycarbapetemases, but also there are contributions of altered penicillin binding proteins and porn mutations that can impart resistance. Jessica talked about what a pain in the what this organism can be for providers who are trying to treat this, and also for infection prevention and stewardship personnel. This is data from a trial that I was a PI on that should be coming out soon in New England Journal of Evidence, where essentially we started this before we had new agents, and we compared colistin plus placebo to colistin plus meropenem. These are polymixed antibiotics. This was the hammer, the only tool that we had back in the day. What I want to really bring out to you is we had mostly Acinetobacter in this trial. And while we showed that, combination therapy had numeric advantages in many cases overall in terms of decreased mortality compared to monotherapy, didn't reach statistical significance. But look at these mortality rates. We're talking about mortality rates of 40 to 45%. So again, the polymyxin era should be behind us, except when there's absolutely no other options. And our newer agents offer more effective opportunities. Unfortunately, we're very limited in CRAB to what we can use. First of all, if sulbactam is active, and in the US, we give this drug as ampicillin sulbactam. If sulbactam is active, it should be used if you have a carbapenem-resistant Acinetobacter. Other than sulbactam, if you have resistance to both carbapenems and sulbactam, we don't have a lot of good options. I really think we need to avoid polymyxins whenever possible. The newer tetracyclines, particularly minocycline, tigecycline, and ribocicline, in vitro are very encouraging, but we don't have great data. And I think there are some PK and breakpoint concerns with some of these agents. Cefiderocol has very good in vitro activity currently against Pseudomonas. I don't think we can rely on it as a single agent for serious Pseudomonal infections. And for if we have resistance to sulbactam and carbapenems, what do we do? If there's a serious infection here, and this, I think, combination therapy, if you want to use cefiderocol, maybe in combination with one of the tetracycline derivatives that I mentioned, these might be a reasonable option. I want to switch and wrap up just describing some controlling resistance in the hospital. There's no silver bullet here for prevention of resistance. It's a combination of old school hand hygiene and gowns and gloves, taking care of the environment, getting those devices that Jessica was talking about, limiting their use and getting them out as quickly as possible. And I also want to show you a little bit of data on the impressive impact of antimicrobial stewardship on gram-negative resistance. The best data for contact precautions, and I'm talking about precautions in endemic settings, not in outbreak settings. Outbreak settings, contact precautions are often part of the solution to stem an outbreak. Endemically, for spread of resistant gram-negatives, there's probably best data and strong CDC recommendations around contact precautions for CRE. I think if CRE is an infection control emergency, you can see rapid spread of this organism that can be a nightmare for units or even hospitals as a whole. There's less data for non-fermenters for things like Acinetobacter and Pseudomonas, but again, there are recommendations from WHO for carbapenem-resistant non-fermenter contact precautions. And I think if you have a difficult to treat or extremely drug-resistant organism that's a non-fermenter, I do think contact precautions make a lot of sense. There's probably least data supporting contact precautions for ESBL producers. I think many people are colonized at the time they come in the hospital and simply not detected until later in their hospitalization. So obviously contact precautions won't help in those instances. Regardless of what you think or what there's data for or not data for, you should follow your hospital infection prevention policies. Be nice and kind to your preventionists and hospital epidemiologists. They're working their you-know-what off, trying to prevent these organisms from spreading in the hospital. Active surveillance screening, I think there's best data for CRE with rectal or perirectal swabs, particularly in hyperendemic settings or for high-risk patients coming in from the community, whether they're from LTACs or prior CRE carriers. For other organisms, active surveillance for CRAB, for carbapenem-resistant Pseudomonas and ESBLs, I think it's really questionable as to the impact and the effect of active surveillance. Can't stress enough how important manual cleaning of patients' rooms are, the daily horizontal cleaning of high-touch surfaces, and the terminal cleaning, post-discharge cleaning. I think the jury's out on no-touch technologies, UV light and hydrogen peroxide, how much they truly add to very effective terminal and manual cleaning. But I think they're an interesting adjuvant, but I don't think there's wonderful, strong data to support their broad use. Water and sinks, reservoirs and outbreaks. I think Jessica covered this. It's important to think about in your epidemic spread of resistant gram negatives. Regional approaches, I think you can't just take everything, close your doors and do everything right in your hospital and pray that everyone else is doing things right. We need collaboratives among long-term care facilities, hospitals, among different hospitals, LTACs, skilled nursing facilities. I think communication and sharing best practices can be quite effective and often necessary to stem the tide of gram-negative resistance in the outpatient setting and in the inpatient setting as well. Just want to wrap up with stewardship. This is Antimicrobial Awareness Week. Stewardship is extremely effective in preventing multi-drug resistant gram-negatives. Here's data from a Bauer et al. Meta-analysis, which showed significant reduction in carbapenem resistance among all the organisms we've talked about, Acinetobacter, Pseudomonas, CRE. A big impact of reducing resistance. And also another message here, I think gram-negative resistance is a huge opportunity for infection control to partner with the stewardship personnel. Antimicrobial stewardship is most effective in reducing gram-negative resistance when coupled with infection control measures. Synergy was quite the message here. Finally, I mentioned 7 days of therapy for many, but not all cases of gram-negative bacteremia. This is data from Brad Spellberg's website, where he shows a bunch of randomized controlled trials with shorter durations of therapy for a variety of different infection and types of infections were equivalent in outcomes and efficacy to long durations of therapy. These shorter durations are often associated with reduced risk for gram-negative resistance, as well as reduced adverse drug events as well. With that, I'm not going to spend a lot of time on the summary. Think shorter durations of therapy whenever possible. We do have choices now for many of our resistant pathogens, and NDM producing CRE, and I think Acinetobacter, resistant Acinetobacter remain huge unmet needs. And I think infection prevention is always critical, but stewardship is also particularly important for gram-negative resistance. And in honor of John Bartlett, and this, I wanted to just wrap up with a quote about John Bartlett. I had the honor of sharing a taxi with Dr. Bartlett in the early 2000s. I was starstruck at that time, and I got to know John later on, and he was a real giant and wonderful person. It's a Tony Fauci quote. He said about John Bartlett, even though there are very few, if any, people in modern times who are world experts in as many areas of medicine, John Bartlett is one of the kindest, most gregarious people you'll ever meet. He has a way of making everyone around him feel comfortable. He also has an amazingly positive outlook on life. For him, life is a joy. He is a legend in the field of infectious diseases, but above all, he's an outstanding human being. With that, I want to turn things back over to Stephen, who is going to help manage our question and answer session. Stephen?
Wow, thank you so much, Dr. Jessica Howard Anderson and Dr. Keith Kay, for your wonderful presentations and talk today. I definitely have circled this since it is almost Thanksgiving time. Be kind, be nice, collaborations, synergy. So I definitely think that we've made a good progress there. In the interest of time, we have many questions in the Q&A. So thank you, each of you, for adding your questions. All of the audience, continue to please put those questions in there. We will go ahead and make sure that we get as many of those answered as possible. And if we run out of time, we'll make sure that we answer them in the recording so that we can send it out to you afterwards. Just wanted to again thank you for your time. First question that I have up here, and I'll toss it to either Dr. Kay or Dr. Jessica Howard. What treatment options do you currently have for these XDR bacteria?
Jessica, do you want to take that one to start?
Sure. I think a lot of it was covered essentially in your portion of the talk, but I think our novel beta-lactam, beta-lactamase inhibitors that you went over, ceftazidime, avibactam, ceftolozine, tazobactam for our carbapenem-resistant Pseudomonas, imipenem, relbactam, and meropenem, vaporbactam, as well, and then cefiderocol and kind of the new arabicycline and things like that. So I think it depends on the bacteria you're treating, obviously, and the resistance mechanism that you think might be there, and whether you have to use combination therapy or not, I think is still an active area of debate and research. We're moving away from polymyxins, as you highlighted nicely, Dr. K, but do you want to add anything else?
Well, I think you hit it on the head. I mean, and again, this is a complicated question. There's not one size that fits all. I think you need to talk to your microlab and find out what susceptibilities, for particularly things like Pseudomonas. You have some options there. You want to find out what susceptibilities are like, so that you can make good empiric choices. And don't forget to follow up on your susceptibility results, because you have empiric phase of therapy, but you should be able to get actual susceptibilities back to some of these newer agents. It might take a little longer than their routine susceptibilities, but you definitely want to follow up on that.
It looks like we have a participant with a hand up. Arnold, if you would like to unmute yourself and ask your question, please.
Oh, hello. Thank you. Am I unmuted?
Yes, we can hear you. Thank you.
Great. Thank you. So especially for Dr. K, who has a long and distinguished career in infectious disease, as did other members of his family, well known. On the other hand, he has been a leader for at least 20 years. I don't want to put a specific number on it, but it seems to me that there's been no fundamental change in the grotesque overuse of less broad, moderately broad, now very broad spectrum antibiotics by people who are fundamentally unknowledgeable and untrained in their use. And I would have hoped to have seen some kind of restriction implemented, much as they do for brain biopsies or cardiac transplants. And that has just simply not happened. What do you, Dr. K, or anybody, see as the future of this kind of issue, which I believe is the fundamental driver of antimicrobial resistance? Thank you.
Thanks, Arnold. Thanks for the kind words as well. I think my dad, Donald K, was a real giant and a colleague and a friend of Dr. Bartlett. So I remember him as well on a day like today. You raised a good point. I always think it's like chemotherapy. Not anyone can prescribe chemotherapy. Only oncologists can. And we don't treat antibiotics like that, even though I think the impact on outcomes and quality of life are probably as good or have a bigger effect in the ID world, as an analogy to oncology and the cancer world. It's just, and unfortunately, Arnold, I don't see that changing over time. I think what we're trying to do is trying to educate people about antibiotic resistance. I think there have been, advances made. The CDC had a big campaign around otitis media in kids and educating parents, and it did decrease demand and use of antibiotics in otitis. That's one example. But there's many examples where overuse continues. I think the focus on shorter durations of therapy is one size fits all, that if we can shorten duration of therapy by 30 or 50% for common things like pneumonia or urinary tract infection, while we're not getting rid of the problem of inappropriate use, we at least can lessen the blow. So it is depressing, and it's not, I don't have a great, silver bullet, but I do think duration of therapy and broader education and awareness is kind of what we need to try to keep doing. But thank you for your comments and questions.
Yeah, thank you for that question. The next question that we have is, do all ESBL infections require treatment with a carbapenem. Sorry, it's a big word for me.
Jessica, why don't you kick that off?
Sure, yeah, and I think this is a good question and one we think about frequently, especially as you're just mentioning the stewardship concerns and the fact that we don't want to use carbapenems for everyone if we don't need to. You showed nice data about how overuse of carbapenems can definitely lead to increased rates of multi-drug resistant organisms. I think I'll refer people to the IDSA AMR guidance that came out I guess last year, the 1.0 that highlights ESBL producing Enterobacterialis. And you know, for invasive infections, bloodstream infections, I do think carbapenems are your way to go. But for cystitis and your urinary tract infections, you may have other options. So if you have fluoroquinolones or trimethoprim sulfamethoxazole, that may be an option. I think the verdict is still out on what to do for these less severe infections and when you can use Pip/Tazo or other antibiotics, but I'll let Dr. K tackle that as well.
No, I agree with everything that Jessica said. I think, you know, for serious invasive infections, pneumonia, bloodstream infection, you definitely want to start out with carbapenems. As Jessica said, cystitis, something like that. I don't, you know, if you, potentially with the concentration that you get in the urinary tract, I think you can get away with other agents. What I would also say is even for the serious infections, once the patient's getting better, you've cleared the blood, they're doing well, they're getting ready to go. If a quinolone is active or a Bactrim, or, you know, a lot of times they won't be, but if they are, you know, you can use these agents. There's nothing that says we have to give the carbapenem for the whole duration of therapy.
All right, thank you very much. Let's see, next question we have. Please discuss the role and need for faster diagnostics in determination of the best treatment and management of antibiotic resistance.
Yeah, I can tackle that first. I think that's a great question. And I showed some data that the initial antibiotic choice or your empiric antibiotic choice can affect mortality. Especially when you have high rates of antibiotic resistant organisms or multi-drug resistant organisms. So I think there's still a lot of work to be done in the diagnostic world, but you also have to have your stewardship team kind of ready to go and paired with some of these newer panels that have employed. So thinking about our rapid diagnostics using PCR panels or even rapid phenotypic testing. If you don't have antimicrobial stewards or physicians that are ready to help interpret those results, you're really not going to see necessarily a benefit in getting to appropriate antibiotic choices sooner. So, Dr. K, anything else to add?
Nope, I think you said it all there, Jessica.
Looks like we're almost at time. Let's get one more in here if we can. What is the mechanism behind advising sublactam-based therapy in CRAB VAP, even though it's been phenotypical resistant?
Yeah. So this is, yeah, I'll start with that. I mean, sulbactam, I mean, there's been actually comparative data that shows that sulbactam is about as effective in many cases as a carbapenem. And I think if you look at the IDSA guidance, I know that they recommend sulbactam. I think they might actually recommend it above a carbapenem as a carbapenem sparing alternative. Sulbactam is not always active. So I think you need to, fall back to your susceptibilities. But, there are people out there who don't trust sulbactam for Acinetobacter, but I've had good experience with it. I don't know if Jessica, if you can comment on it. Certainly, I think it's the best alternative we have if something is carbapenem resistant, if it's sulbactam susceptible.
Yeah, I agree. We try to use sulbactam and particularly high dose sulbactam when we're able to as well.
Absolutely high dose, yeah.
All right, well, if you have additional questions, I know I see a few more hands raised. I apologize for not being able to get to everyone's question. If you have additional questions, please put them in email format. Send those questions to concierge@idsa.org. idsafoundation.org. Again, concierge at idsafoundation.org. I would again like to thank Dr. Keith Kay as well as Dr. Jessica Howard Anderson for joining us today and for this fantastic presentation to kick off AMR week, as I call it. I'd like to also take a time to thank all of you and our audience for participating. This program and others in the John G. Bartlett Education Memorial Education Series would not be possible without the generous support of our industry partners. Today's partner is AbbVie. We'd like to thank them again for their support. I'd also be interested to learn, if you want to learn more about IDSA Foundation, the upcoming webinars that we have. This one will be was recorded and will be up on our website within the next 2 to 3 days. Again, just visit idsafoundation.org. And again, we would like to remind you that if you would like to continue to support the efforts of Worldwide Antimicrobial Awareness Week and present educational opportunities like this to medical students, residents, and fellows to receive AMR education grants, we do have a link on our website so that those grants can be taken in a self-study course through the IDSA curriculum on antimicrobial stewardship. Finally, I'd like to say that our next John G. Bartlett Memorial Education Series event will take place on November 29th, and that will be called The Microbiome and C. diff. Can the gut defend against infection? A link to register as well as more information, again, will be placed in the chat. And then this is, as I mentioned earlier, Thanksgiving time. So as you can well imagine, the Tuesday after Thanksgiving is Giving Tuesday. So I know you have plenty of philanthropic support opportunities and priorities. We hope that opportunities such as supporting the IDSA Foundation are in your mind today that can bring you education such as this. So we really appreciate all of your support. Thank you again as we honor those who serve in this space as hospital epidemiologists, clinicians, researchers, and the broader community. Have a fantastic day, and we appreciate all that you do. See you at our next event.